morning, everyone. Thank you very much for this opportunity to give you a very brief overview of a proposed approach we've developed, how to engage community and community leaders in Ebola, but generally in IPC. It's not only related to Ebola. So when we reflected on the real devastating and far-reaching impact of Ebola outbreak, we reflect on that, and it eliminates some limits of the sort of conventional biomedical approaches we have, and that's in terms of the knowledge of the community, of the cultural context, also in our interventions. I've put that interventions in brackets because we refer to more as responses, because from a community perspective, interventions could have quite a negative connotation as well. And evidently, there's this ongoing gap in the evidence we have, and how do we translate that into effective measures, responses that are also culturally sensitive. Also, it seems to suggest that what we need is early and active and sustained engagement of the affected communities, as we've heard from previous speakers, but their trusted leaders and the networks. Also, we need to validate and really build and harness the lay knowledge. Quite often, it's rejected, it's felt it's not science-based, it's not evidence. We reject that, and that's a mistake we make. And the critical thing here is really for us to improve the cultural congruence of the responses we have, but importantly, without compromising safety. And we need our responses to develop and employ those in partnership with, by, and for the community, because ultimately the affected communities are the very repositories of unrecognized assets. That's knowledge, its structures, practices as well, that we need for effective and contextually appropriate responses, because ultimately the community is part of the solution and it's actually the pivot of success. So based on understanding that we need community engagement, my colleagues and I, we developed this approach called the CARE approach. The acronym stands for Community, Assets, Risks, Responsiveness, and Evaluation, and I'll go through that. It's based on what we call practice-based evidence, and that's about the limits of conventional approaches we have, also on the strengths of participatory work involving communities and multi-sectors. And importantly also, we contacted various community leaders and experts in several African countries affected by Ebola and other diseases to get their opinion, also people who survived VHFs and Ebola, international experts, and also people who are quite leading world figures in community engaged approaches to really ground this model on all this expertise. So we came up with 8 key steps, and I'll go through these very briefly. First of all is to prepare to enter the affected community. As you know, medical teams won't enter a high-risk environment without the proper PPE. Equally, don't enter a community without knowledge of that local culture and the government structures. And how we can do that is to identify someone who's trusted and respected by that community that can serve as that cultural guide, almost like a broker, that can help you to tell you, how do I approach the leaders? In some communities, it might be approaching a leader with a present like food, and other communities that might be absolutely patronizing. You don't do that, it's an offense. You need to know what is the governance structures, and also use the local communication strategies to announce that a team will come into the community to try and prevent the communities being caught out by unexpected arrival of medical teams, people in space which is very alien to them, and that can result in fear and anger and potentially in violence as well. A critical point here is to enter the community with what we call cultural humility. That's an understanding that we can never fully understand someone else's culture, but it's that openness to know I have my biases, I have my preconceived ideas, but I have the openness to learn and to challenge my own beliefs, what I have of someone else's culture. If I do that, then I will validate that community expertise, their knowledge, their realities, and also what we refer to as a community protocol. That refers to the local customs, the beliefs, and the practices in that specific setting. So it needs really critical self-reflection, openness to learn, to critique yourself, and importantly here is when we enter the community, you have to go with a leader who is respected by that community. And then we want to identify who are the broader leaders, including here female. Quite often in approaches, we go for the male leaders or existing community organizations, but we need to access the female leaders as well. This is relatively simple to do. This is an approach we use in different communities. You go in with a community representative who is respected, and you ask these key questions. Just simple. Who do you go here for advice? when there's a problem in the past, who came together to solve it, who get things done, in other words, who should be involved, who are some of the other respected community leaders. This could be older people, women, the youth, etc., and whose voices are the most influential in making decisions in that specific community. And that knowledge starts to rebuild that foundation for a community medical partnership. Regular meetings are critical, but quite often in poorer settings, communities are often exposed to outsiders who call meetings. Then at the meetings, certain rules are given. You have to follow this. And then the experts from the outside get quite disillusioned when people don't turn up. But is it really a surprise? What we say, turn it around. The community leader should call a meeting, and someone from the medical team should go be invited. And that whole purpose of that meeting is a two-way learning. It's not, as I said at the bottom, about this is what you need to know. It's going with the openness to say, what can you teach me? Both from the so-called medical expert, but all the community expert, a dual openness to learn and move forward. Also, what we need to do is assess the community readiness. How ready are they for change or to engage with the medical team? And there are 5 dimensions here. Look at what's the knowledge of the issue about Ebola or any other disease. Do they know what efforts are in place already? How many teams are in place? Where are the health facilities, lay community health workers? What is the leadership's attitude towards the problem or towards working with the medical teams? What is the community's understanding of Ebola or another disease, and what resources are in place that we harness to help and strengthen our approach? And then we need to discuss with the leaders, with the community, what is required IPC measures, and then we try to identify where we might be able to make some adjustments to make it more cultural congruent, but clearly not to compromise anyone's safety. Another important step to do is just mapping. And we put in here children is very important to include. We've done a work recently in a rural town in South Africa where we look at the social determinants of child health. When we spoke to adults, no one discussed alcohol, drugs at all. When we spoke to the young children to start mapping, they said that's the key driver. So we could go back to the adults and say, actually in your community, the children seem to suggest that alcohol and drug abuse is a problem. Is this true? And then they start to open up. So again, there's a list of people we could involve, and importantly also Ebola survivors. It's really important to work with them. They could be peer health promoters. It can help to destigmatize them and their families, and also to start building community cohesion again. Also, we need to map what are the risks in terms of that community protocol, about how we deal with the sick and the ill, to identify areas we can intervene. So if you look at a conventional approach, this is just an example. This community, you can see a lot of problems. AIDS, alcoholism, GAMS, slum housing. That's a very traditional way we're looking at things, problems. But if you slant it towards assets, the same community, you can realize, oh, actually, there are other assets we can work with. There is resources, there's the police, there's individual capacities, cultural organizations, etc. So it's a fusion of the two approaches. And very simply, if you don't have maps of the community, you can draw it, put on the risks, the community help you with this, or you can take it a step further, and you have to GIS mapping as well to identify where are the risk areas and where are your assets, and try and work with that to strengthen your response. So that whole process of community assets mapping, it moves away from, I think what we all quite often have is that deficits mentality, where we view communities as just this big bundle of problems, and communities start believing they only have problems and outsiders must sort it for them, which is not actually factual. So we can, through that process, turn problems into assets. For example, in Sierra Leone, when the nursing and medical colleges were shut down, the student, which was not an asset, but the students immediately find out how many bicycles are in the community. They use the bicycles to start reaching out and doing health promotion in communities. So it's turning that problem into an asset, into a positive response. And then people can start seeing communities differently as well. If you look at the bottom, your left, it's a community we worked with, again, in South African context. Very poor, no housing, malnutrition. And when we start mapping assets with them, we realize that once a month there's a whole community carnival, there's food, and we use that as a health promotion tool to work with communities. So turning it from a very bleak picture to there's some assets in the community. Then it's a critical point here is to develop what we call the community medical protocol. And that's based on all that knowledge you've gathered through your community meetings and to see if it's culturally congruent, but it's not to compromise any safety standards at all, but it's to try and sort of preserve very important cultural concepts at the same time to reduce risky practices. And Any disagreements must be addressed immediately, especially addressing any myths and rumors that might be prevalent in the community. These are some examples that community members gave us how we can adjust protocols, and some of this you will see the WHO and other people have responded to already. I won't go through the whole list, but it's basic things that people ask for just to show respect to the person who has the illness and also to people who have died. So really, we're trying to preserve the cultural concepts, but any options of any alternatives must be decided with the community. And that's really to prevent any community fear, anger, trauma, maybe violence by unrecognized practices in the community, as we've seen in the press. Communication is critical, but very much is a two-way process, and that's to share that knowledge. As we know, word of mouth quite often is a very important means in many communities, but it's also vulnerable to spread of rumors and misinformation, as again we've learned, where there was a belief that treatment centers might be spreading Ebola deliberately and ask people to leave. And again, those sort of rumors and myths we must address very quickly. So we need a system for regular feedback, but we also get feedback from the community and to the community. And in addition to that, personal communication is to identify with the community, how do you learn about events in your community? What is the best way? And you can see again some examples, and on your left, where street theatre was used as well to demonstrate how to prevent the spread of Ebola. As with any program, you need your monitoring and evaluation process to find out what are successes, the failures, look at the cost effectiveness, and throughout that, keep the focus on that community and cultural context of that whole continuum of prevention and control. And these are some of the overall questions we could ask. It's just how responsive are the overall efforts to adhering to this collaborative community medical protocol? Is it culturally congruent? And how is this protocol perceived by outsiders? For example, WHO. Is it improving the responses? Is it effective? If not, we need to address that immediately. But of course, you always need your baseline indicators. And again, we say develop that with the community. Traditionally, it's done from the outside. We say work that in partnership with the community. Specifically, if you think about capacity building, do the communities feel, I've learned more? Equally, the health providers, have they learned more knowledge as well? And we argue through the regular meetings, have a participatory assessment process that people can give feedback. Yes, you're listening to me. Yes, I've learned more, and still identify other risks as well that we need to work on. And very importantly, again, to stress, really engage the Ebola survivors. They are the people with the lived experiences. We can harness their expertise and learn from them to make it better for other people and strengthening our systems. And wherever we need to make adjustments, again, communication, feed it back to the community. The next step is plan for ultimately for leaving, but a sustainability. And a moment, you know, with any team, you won't stay there forever. Start that process early on so people can understand eventually the outsider team might leave, but will leave with capacity in the country. Because we feel it should be the whole empowering process of prevention, of treatment and self-care by the community, for the community, but in partnership with the local authorities. So then you can start building that network and local capacity that the community itself can start with early action if there's another problem with Ebola or any other disease as well, to prevent that before it's a massive outbreak. So in conclusion, as we try to demonstrate here, is from our side, from a very community building perspective, we argue that disease outbreak prevention and control, it needs that environment, needs to be created between the community and the medical teams, whether the teams are from the same country or from the outside. It's a co-creation that should happen. That should be grounded in cultural humility, that openness to learn, to be critical of your own misunderstanding and prejudice, reciprocal trust, both ways, and respect, and that learning, that we learn together. It's not what you should know, it's what can you teach me approach, and to think about capacity building all the time, leaving that capacity in a country, don't take it away, and leaving them vulnerable again. And that's important to create that community medical protocol that respects some of those important cultural concepts, but it doesn't compromise safety by working and reducing some risky practice that's aligned, and also to keep that community protocol in mind, and we can only understand that if we engage with the leaders. So this approach that we have, it still requires rigorous field testing, but as we said, it's based on feedback, on experiences from different leaders. in the field and community members and leaders themselves, and it is very adaptable to particular contexts, because that's important. Not, as we know, communities are very, very different. It can adjust itself to that, and it holds that potential that through that community empowering action, capacity building, that it can prevent or add towards the prevention and control of future outbreaks by building that local capacity through this communal medical partnerships. And if we do that, then hopefully that we can, with our responses that we have for Ebola, that we can frame that within a concept of a care approach. I would like to acknowledge all these people, specifically the community leaders. They are not named, they didn't want to be named. Some community members who added to the development of this approach. You can see the co-authors, and then I can, the other two authorities, and obviously EPIC for bringing me to this conference. So with that, I leave you and say thank you very much.